Yeah, good morning. Thank you, Dr. Anju. See, I'm just going to put some cases which I have come across. So DCR unexpected surprises, what we see is either it's an anatomical surprise or a pathological surprise. So anatomy, so first is when you dissect the sac, the next is to, you have to enter into the nose, that is lateral wall of the nose. So when you, in that step, you can have ethmoid coming into it. So at that point of time, you will be confused because the ethmoid bone is very thin, and second, it is to differentiate it from lacrimal sac mucosa, ethmoid bone is very thin. Then the mucosa is also thin, and it is less vascular and less adherent to bone also. So when I initially come across, because there is a racial variation, even in South, I think. When I did fellowship, I didn't come across much ethmoids, but when I'm operating in this Cochin, I come across around 30% of anterior ethmoids. But when I look into the literature, around 46% had this anterior ethmoid. It has been radiologically studied also. So radiologically, around 59.23% had ethmoids coming in the way of your ostium. So this, we have to be very careful, and the main thing is to differentiate between the lacrimal mucosa, lacrimal sac mucosa, nasal mucosa and ethmoid sinus mucosa. So this is the nasal mucosa, and you can see the thickness of the nasal mucosa. It's very thick, but ethmoid mucosa is very thin. So this is one anatomical surprise. So coming to second anatomical surprise, we know the normal anatomy, upper canaliculus, lower canaliculus, joints, and form the common canaliculus. But in this I have not come across, but reported by Dr. Javed, that is distinct canalicular openings into the lacrimal sac without a common canaliculus. Even though this is not very problematic, you have the take-home message is you have to probe both the canaliculus to see the patency, whether it is opening to the sac. So now coming to the pathological surprises. So this is a 4-year-old child presented with recurrent lacrimal abscess, and IND, he had already undergone IND 4 times in the past from elsewhere. Probing also done 2-3 times. And the parents are repeatedly telling me it is, syringing is patent. So now what to do? And he is 4 years now, but not willing for dactylocystogram, which will give me some clues. You can see the scar, and this is the clinical picture. So what I did is, since I am seeing the child for the first time, I also posted him for probing syringing, plus minus DCR, because I have already discussed and have taken consent also. So now intraoperatively, any guesses? So this was a case of lacrimal sac diverticulum. It's rarely seen, but this repeat INDs and the patent on probing, patent on syringing, think about lacrimal sac diverticulum. So actually I have entered into the pouch, and then eventually I did DCR for him, and he did well. So this is another case, 50 years female. I did DCR for NLDO. Intraoperatively, the sac was abnormally very much thickened. So I was just wondering what is. So I did a biopsy and turned out to be sarcoidosis. So while after the surgery, on the 1-week review, while I was asking the history, she was taking treatment for chronic asthma, chronic cough, thinking it as chronic asthma. Eventually, she was diagnosed to have systemic sarcoidosis, and this we have published by Dr. Shebin in IJO. So intraoperatively thickened sac, always do biopsy. The other part, which very commonly missed condition, is lymphoma also. Coming to my 5th case, so he's a 50-year-old medical practitioner. Came for DCR because he's already a doctor, so he knows what pathology is going on. So on examination, you can see there is a mucosal-like thing well below the medial canthal tendon, displacing the lid up. The globe is also a little pushed up. And I did syringing. Syringing showed an atonic sac. So since I did an image, because there was, you can feel a mass here, but it's not very typical of mucosal. So CT scan showed a mass, but the sac was seen separately from the mass, and you can see a mass here. And on the other side, he has got an ethmoidal mucosal also. But interestingly, the nasal anatomy is grossly disturbed. So I took an ENT consultation, and they said nothing to be done from their side. Ethmoidal mucosal is not causing any problem. You can go ahead with your management. So intraoperatively, the mass was distinct, And I did an excisional biopsy with lacrimal intubation. The mass was actually pushing the sac, causing pseudo-NLD, causing atonic sac. And the histopathology turned out to be cholesterol granuloma. So this was also an intraoperative surprise, even though I was expecting something in the preoperative evaluation. Coming to the sixth case, again 50-year-old encysted mucosal came for DCR. So you can see this is the clinical picture. There is a mass below the medial canthal tendon. Only thing, the mass was little firm, and so we did a CT scan. Which reported as infected retention cyst, but you can see a bone scalloping. So in this case, we were a little confused. This doesn't look like this thing. I mean, DCR, Rho plus NLD. So what we have done is posted for DCR versus DCT, depending on the frozen section. So when we opened, it was little thick. So we did a frozen section and turned out to be plasma cell neoplasm, based on which we did DCT and turned out to be lacrimal sac plasmacytoma. So this was also an intra-operative surprise, and he did well with a 10 years follow-up now. Coming to the seventh case, 48 years female, diagnosed cystitis, had already undergone endoscopic DCR with the FES twice by the ENT surgeon, and she's a known case of treated carcinoma breast. So this is her clinical picture with encysted mucosal with inflammation above the medial canthal tendon. This is a CT scan picture. You can see the already done ostium is already there, but her sinuses are also full. So again, I took an ENT consultation because even actually referred from ENT, still I took again and repeat ENT consultation. And this was, even though posted for DCR, initially we did DCR and later failed, and finally we did DCT. It turned out to be a fungal granuloma, and she was given systemic antifungals. So this was another surprise, 46 years NLDO. I posted her for DCR, it was one late evening. So after, this was her first, after the incision, it was started bleeding heavily. So I thought I will post, and she was uncooperative, so I thought I'll just post her under GA on a later date. So when she came back after 2 weeks, it was like this. Any guesses? So this was a case of rhinosporidiosis, and then I did DCT and she did well. So to avoid pathological surprises, we had to do biopsy like sac thickening. We had to do biopsy when sac thickening, abnormal discoloration, irregular mucosal surface, any systemic diseases like autoimmune, malignancy, sarcoid, vagus, lymphoma, leukemia. All these things you have to ask before you take up the patient for a DCR. And any failed DCR, then again suspicion based on history, scans, nasal endoscopy, and intraoperative findings. Clinical significance of routine lacrimal sac biopsy during DCR has already been in 3,865 lacrimal sac specimens. Specific pathology was found in 5% of cases. That is very, very important. I will just stop with this slide. This is how taken from Dr. Arun Singh's pathology textbook. Each line he has written is very, very important. I'll take 30 seconds. So maintain a high level of, how to avoid surprises during DCR. 1, maintain a high level of suspicion. Examine the reflex from irrigation of the lacrimal system. Press on the sac. Beware of firm, incompressible, immobile masses. Press on the sac. Examine for any blood-stained tears. Beware of a mass above MCT. Peroperatively, if the sac looks like anything other than inflamed sac, obtain a biopsy. Perform a nasal examination. Beware of skin ulceration, telangiectasia. In the presence of lacrimal sac max, examine for lymph nodes. If in doubt about the appearance of the sac, do biopsy. In the presence of DCR being performed on a patient with history of lymphoma, leukemia, always biopsy. So to conclude, expect the unexpected, careful preoperative, tackle intraoperative surprises, excellent outcome. Thank you.
Thank you, Dr. Marian, for the interesting talk.